Red yeast rice can act like a statin, and that is exactly why we need to treat it like a drug. This is not a video claiming red yeast rice is fake. A properly fermented product with enough active monacolin K can lower LDL cholesterol. The problem is that the ingredient making it work is chemically identical to lovastatin, while the label may not tell us how much we are actually taking. So red yeast rice has two ways to disappoint us. It can contain too little monacolin K to work, or enough monacolin K that we should have treated it like medication from the beginning. First, what is red yeast rice? It is rice fermented with a fungus called Monascus, usually Monascus purpureus. That fermentation can produce compounds called monacolins, including monacolin K. Monacolin K is chemically identical to lovastatin. It lowers cholesterol by blocking HMG-CoA reductase, an enzyme the liver uses to make cholesterol, which then encourages the liver to pull more LDL particles from circulation. The body does not award a safety bonus because a statin-like molecule came from fermented rice instead of a pharmacy. And yes, it can work. Standardized preparations containing enough monacolin K have lowered LDL by roughly 15 to 30% or more in some trials and reviews. But that sentence has a very important word: standardized. A specific, measured preparation in a clinical trial is not the same product as every bottle using a red rice photo and the phrase heart support. One major retail analysis looked at 28 red yeast rice brands. None listed the monacolin K amount on the label. 2 had no detectable monacolin K, while the others varied by more than 60-fold at the same stated amount of red yeast rice. When recommended daily servings were considered, potential monacolin exposure varied by more than 100-fold. That means 2 people can follow 2 labels perfectly. One may receive almost no active drug-like compound. The other may receive something closer to a pharmacologic lovastatin dose. The front label might say 1,200 milligrams of red yeast rice. That is the weight of fermented material, not necessarily the active dose. It is like buying coffee without being told the caffeine content. This also explains why red yeast rice studies seem contradictory. Trials using measured monacolin containing preparations can lower LDL, but in the sport trial, a specific commercially available red yeast rice supplement did not lower LDL significantly more than placebo, while low-dose rosuvastatin produced a large, predictable reduction. That does not prove all red yeast rice is ineffective. It proves that the bottle is not the category. The best cardiovascular outcome evidence also came from Shuizhikang, a particular standardized extract studied in people who had already experienced a heart attack. We cannot transfer those results automatically to any random retail supplement. The best outcome trial tested a consistent product, not the supplement aisle as a group project. Now the regulatory paradox. The FDA says products with enhanced or added lovastatin cannot legally be sold as ordinary dietary supplements in the United States. But a product with very little monacolin K may stay on the supplement side while doing very little for LDL. So the ingredient that makes red yeast rice reliably effective is also the ingredient creating its regulatory problem. Enough active compound to work may make the product look more like an unapproved drug. Too little may make it an expensive jar of red optimism. Now contamination. Red yeast rice fermentation can also create citrinin, an unwanted mycotoxin that may damage the kidneys. Citrinin does not lower cholesterol. It is the uninvited guest produced alongside the compounds we wanted. Testing has found major variation in citrinin contamination, and some contaminated products have even carried citrinin-free claims. That does not mean every bottle is contaminated. It means marketing is not batch-level laboratory proof. With red yeast rice, we are not only asking how much active ingredient is present. We are also asking what the fermentation accidentally created beside it. Now the side effects. Because monacolin K is lovastatin, a potent product can cause statin-like muscle symptoms, liver injury, drug interactions, and, rarely, severe muscle breakdown called rhabdomyolysis. Possible warning signs include unexplained severe muscle pain, marked weakness, dark or cola-colored urine, reduced urine output, yellow skin or eyes, unusual fatigue with nausea, pale stools, severe abdominal pain, facial swelling, breathing difficulty, or a serious rash. Dark urine plus significant muscle pain or weakness deserves urgent medical evaluation. That is not a drink more water and see how Monday goes situation. Some clinical trials report few safety problems. That is reassuring within limits, but many trials were short, used a selected standardized preparation, and were too small to reliably detect uncommon serious harms. Rare does not mean imaginary, and an undisclosed dose makes risk much harder to manage. Interactions matter too. Monacolin K should be treated like lovastatin when medications are reviewed. Certain antibiotics and antifungals, HIV medications, cyclosporin, fibrates, high-dose niacin, amiodarone, verapamil, substantial grapefruit intake, and other drugs can raise exposure or muscle risk. Combining red yeast rice with a prescription statin is especially questionable. We may be stacking two versions of the same pathway while knowing the dose of only one. Alcohol, liver disease, kidney disease, pregnancy, breastfeeding, frailty, and a complicated medication list all raise reasons for caution. The higher someone's cardiovascular risk, the less appropriate it is to gamble on an unknown supplement dose. Someone with familial hypercholesterolemia, very high LDL or ApoB, diabetes with elevated risk, established plaque, a previous heart attack or stroke, or a high coronary calcium score needs a defined treatment target and a predictable plan. That is not the moment to choose between possibly ineffective and possibly an undeclared statin dose. What would good quality testing look like? At minimum, we would want a batch-specific certificate of analysis matching the bottle's lot number. It should report total monacolin K per daily serving, a numerical citrinin result with a detection limit, heavy metals, microbial testing, identity testing, and the name of an independent accredited laboratory. A logo saying GMP, premium, pharmaceutical grade, or lab tested is not enough. We should verify genuine third-party certification through the certifier's own database rather than trusting decorative badge art. But even excellent testing cannot fully solve the paradox. A clearly potent monacolin product may cross into unapproved drug territory, which helps explain why the information consumers most need may be missing. So are we buying an ineffective supplement or an undeclared drug? If the label cannot answer that, the red flag is already waving. Now the better decision tree. Bucket 1. Mild LDL elevation and low cardiovascular risk. Start with the basics that improve far more than one lab number. Reduce excess saturated fat, replace it with unsaturated fats, increase soluble fiber, exercise, address weight if appropriate, stop smoking, improve blood pressure, and manage glucose. Psyllium, oats, barley, beans, lentils, fruit, nuts, and plant sterols can produce modest LDL reductions. They are not substitutes for medication when risk is high, but they are more transparent tools than mystery monacolin. Bucket 2. Borderline or intermediate risk with uncertainty. Use proper risk assessment instead of guessing. The 2026 dyslipidemia guideline emphasizes prevent risk estimates, LP(a), at least once in adulthood, selective ApoB measurement, and coronary artery calcium when it can clarify a treatment decision. Bucket 3. A clear indication for medication. A regulated drug offers a known dose, predictable LDL reduction, pharmacy interaction checks, outcome evidence, and a clear process for changing treatment. Statins remain foundational. Depending on risk and tolerance, clinicians can also consider ezetimibe, bempedoic acid, PCSK9 targeting therapy, or combinations that use lower doses. Bucket 4. Someone who believes they are statin intolerant. Red yeast rice is not automatically the escape hatch because it may expose that person to lovastatin again without disclosing the dose. A better plan is reviewing whether symptoms truly track with the statin, checking thyroid issues, interactions, or other causes, trying a different statin, a lower or alternate day dose, or using a regulated non-statin option. Natural is a description of origin. It is not a safety rating. The final verdict is balanced. Red yeast rice is neither a miracle nor automatically a scam. It is a pharmacologically active but often unpredictable product. When it contains enough monacolin K, it can lower LDL because it works like a statin. That same fact gives it statin-like side effects and interactions, while variable potency and citrinin add problems a prescription label is designed to reduce. If this helped you see past both the supplement hype and the reflexive dismissal, tap like, subscribe to Longevity Compass, and check the description for our Amazon KDP book and safer tools for improving and tracking cardiovascular risk. When red yeast rice works, it works like a statin, and that is exactly why it should never be treated like an ordinary supplement.